cover it all. So what we're going to do today is just briefly talk a little bit about the data and why focus on aging. We're going to do some sort of level setting about what we mean in terms of long-term care and the kind of talk a little bit about the landscape of aging and long-term care. There's a whole acronym soup that goes with this that I'm going to try to hopefully tease out for some of you. Some of you may know this better than I do, so if I get anything wrong, please tell me. It's a complex patchwork of services and organizations, but hopefully this will help give you kind of some framing on that. And I'm really hoping to dive into what I identified and I think are kind of some key opportunities if you're thinking about critical access hospitals and population health, what I think are kind of 4 key activities that might be related or might be good opportunities, and then kind of pull that together with some alignment about value-based reimbursement. So I talk fast, but I'm happy to have questions, so you can either put them in the chat or somehow kind of flag me. Because I know it's hard to sit and listen to people talk the whole time. It's really nice to be able to have a dialogue. So we'll definitely be able to do that after I get through the content, but I'm happy to try to address questions and comments while we're going through as well. So with that, we are going to dive in. So why focus on aging and population health? So even if you're fairly new to the rural health community, I'm pretty sure you've heard that rural communities are older, sicker, and poorer. Older, sicker, poorer. So we're going to focus on the older piece here. I didn't dive into some of the traditional data. I tried to highlight something that might be a little bit different here. Yes, the median age is about 6 years higher in rural communities. About 25% of the nation's seniors live in rural communities compared to 21% of the overall population, so we have a higher proportion. The thing I really wanted to call out for you here today is that what we kind of call the oldest of the old population is rapidly expanding. So a lot of times when you look at data, they show 65 and older. Sometimes they will also split 85 and older. So that's kind of that oldest of old, I think, is a really important group for us to be looking at because they're the ones that are even more likely to need services and support. So people age 90 and over now comprise almost 5% of that population. So if you're 5% of the people older than 65 are now older than 90, and that is growing and is anticipated to be 10% of that group by 2050. The other really dichotomy there is that, not surprisingly, I don't think surprisingly, women age 90 and greater outnumber men by 3 to 1. And when we think about some of the caregiving and financial stability issues, over 80% of those women are widowed, while more than 40% of the men are married. So women tend to live longer, and particularly in those generations, the men tended to be older than the women anyway, so you have a lot of older single women and growing numbers of that. So just a couple of graphs to kind of illustrate some of these points. Population health or population growth in older adults is increasing overall in the country, but it is proportionately higher in rural. The colors on this don't show real well. This is not a rural specific graph, but I wanted to highlight for you the orange blocks here are the proportion that's 85 and older, and you can see how that's both increasing in proportion and in just sheer numbers. So this is projections out to 2050. We're sitting here at 2020, so we'll continue to see both kind of the proportion and the just sheer volume of older adults growing, and particularly in that kind of oldest of old group. And I realized I skipped my mom and dad. This is my mom and dad. This is another reason that it's important to focus on older people and aging. They're not quite in that 85 plus, but they're getting there. This is a few years ago on their 50th wedding anniversary. They do not like urban areas. When I used to live in the Twin Cities, they used to park their RV about an hour outside of it, and I would have to go see them because they didn't want to have to come into the city. So their permanent address is in western Wyoming, and they just bought a place in rural Arizona, a little more urban than where they're at in Wyoming, but still pretty rural. So this is another reason to focus on aging in rural communities. And I'm guessing you all know folks like this as well. So they are still quite healthy, still quite independent. but I think have started to recognize that they're kind of on the edge, that they might start to need services to be able to remain in their home independently. Finally, if I am late enough turning my slides into Caleb Andrews, sometimes I get new data. I was so excited to see just this Tuesday that the folks from the University of Minnesota Rural Health Research Center released a new paper on characteristics of counties with the highest proportion of the oldest old. I knew that Carrie Henning-Smith and teams were doing some of this work, but the timing was fantastic, at least for me. So this is a link to this article, and you can see here the counties that have the highest percentage of folks that are 85 and older. So anybody who lives kind of in this middle here, we're old in the Midwest and getting older. So there's a nice summary and some additional characteristics they highlight. There's, I think, 56 counties that have more than 5% of their county population is 85 and older. So they highlight some of the characteristics there. So hot off the presses, that one just came out Tuesday. So we have a growing proportion of older people and a growing proportion of the oldest old folks. And so what kind of challenges does that, and opportunities, does that leave us in terms of population health? I'm not going to spend a lot of time here because I know you guys talked about this in some of the other areas of the FLEX program, but certainly access to medical services is a big one, particularly, you know, the basics of the primary care and hospital, but as you might need other kinds of services, there's access issues across the board. Age-friendly housing can be a real concern. I'm guessing I'm not the only person who had grandparents' houses who had long, narrow staircases and tiny little bathrooms. A lot of times in rural communities, houses are older. They're not necessarily built for aging adults or folks that might have mobility issues, and sometimes there just isn't other opportunities in local communities. Transportation, a lot of our rural communities, if you don't drive, you're really having struggles with transportation. Nutrition, access to healthy foods, social isolation is a significant issue and growing. The folks at the University of Minnesota have been doing a lot of nice research calling out that issue as well. Caregiver support is particularly, I think, growing to be a recognized challenge as we have folks getting older, and those of us that may be in a caregiver role also growing older compounds that, so lots of opportunities around how do we help caregivers. And then finally, in financial insecurity, sort of across the board, but you also see that in particularly with older women who may not have the same level of Social Security that they might have if their husband is still living. So financial insecurity is a growing issue as well. So high-level kind of summary of what those challenges might be. So that's kind of our demographics and big picture. We're going to shift now a little bit to talk about what does it actually mean when we're talking about long-term care. I'm going to guess that every single one of us probably has some different picture in our head when you say the word long-term care. What does that mean? And the reason that we all have varied pictures is because it's a really broad term. So this definition is actually from the National Institute on Aging. It's a variety of services designed to meet a person's health or personal care needs during a short or long period of time. So services are particularly designed to help people live independently and as safely as possible when they can no longer perform everyday activities on their own. And the most common type of long-term care is personal care. So it's help with everyday activities, also called activities of daily living. So one of the acronyms that you will see very commonly in the acronym soup that is long-term care is ADLs, activities of daily living. So toileting, bathing, cooking, transportation and medical appointments, all those things kind of fit into activities of daily living. Long-term care is provided in different places by different caregivers depending on people's needs. So one of the important things to call out when you're thinking about population health strategies is that most long-term care is actually provided at home by unpaid family members and friends. So here is a summary of kind of who are informal caregivers and how critical they are to the system. And I'm going to guess most of you, many of us at some point in our lives, and maybe right now, have served in this sort of informal caregiver role. So whether or not that's help assistance with everything from assistance with groceries or cleaning or those types of things. So it can be a little bit or it can be a lot. You could actually have somebody, a lot of times folks have people living with them and are really kind of hands-on on their day-to-day caregiving. So you see that as that continues to increase, then most informal caregivers fall in that 55 to 64 age group, but there are several that are in the 75 and older, and that is likely to grow as we continue to see an aging population. When you are in some of these populations, a lot of times families are still raising their own children or are kind of still in the workforce. And so there's a lot to balance for informal caregivers, and caregiver support can be a really key aspect of trying to support long-term care services.
While we're still on this topic, I wanted to mention that not just the services and how important they are, but major life decisions are based on this exact thing. My family back in Colorado, my little brother and his Brady Bunch situation with 6 kids live a house away from my mom, my dad, and my grandmother. My mom is pretty much full-time caregiver for my grandmother, who's got early stages of dementia, and my father, who's wheelchair-bound due to a stroke. So when she's buying a house, she's making sure it doesn't have stairs. She's making sure it's close to my little brother, who's going to be there to help all of them. So it's a whole lot of things to consider just as part of your life. It's not just, whether or not the hospital provides that stuff. So it's a huge impact to your community, where you live, all of that stuff. To Carla's point.
Yeah, absolutely. Thanks, Caleb. That's a really good example that kind of just brings it home for the impact here. And like I said, I'm going to guess most, if not all of you, have been in some sort of family or friend situation where there's been needs for informal support. And any way we can support the informal caregivers is going to take less strain, kind of help reduce strain on the formal caregiving, which is most of the rest of what we're going to talk about is kind of more the official kind of services that you would either purchase or access to provide support. So this is a little bit of the web. I stole this graphic from a paper that the Evergreen Health Panel did on long-term care, long-term services and support. So when we're talking about this, there's kind of 3 different angles. So there's lots of different angles to look at it, but there's home-based services, there's community-based services, and there's facility-based services. So, and then there's kind of service types that cross over those different types. So when you think about facility-based services, the easiest one to think about is assisted living or nursing home or skilled nursing facility. That's probably the cleanest cut. But there's also skilled nursing care that might be happening that might fall into 2-year swing beds. There can be things around nutrition that come with that. And then when you think about community-based services, you might be thinking about senior centers, adult daycares, congregate meal sites, all the types of things with meal programs, transportation, social services, those sort of cross both home and community-based services. And then you have kind of this bucket of case management and training and health and promotion and disease prevention, different therapies that could really be across the board. So you start to end up with a somewhat complex web of community, home, and facility-based services, depending on where people are in their trajectory, whether or not they had a recent hospitalization. They might kind of bounce back and forth between several of these services, depending on where they're at with their current needs. And it's one of the reasons it's so hard to talk cleanly about long-term care services. One of the other reasons that I wanted to just spend a little bit of time kind of on definitions is the payment aspect for the services. Medicaid is the primary payer for most, particularly of the institutional or facility-based services, but also the community-based long-term care. And this is where you get into some of the acronym soup in terms of long-term care. So in the Medicaid lingo and often kind of spread out into then more broadly, what this is often referred to as LTSS. So if anybody's ever heard LTSS, it means long-term services and support. So it's a lot about the types of services we've just talked about. And then to layer another acronym in terms particularly in Medicaid lingo, there is oftentimes a desire, rather than to have people go into nursing homes or long-term residential care, to use home and community-based services, or HCBS. So as in just about anything else in healthcare, you can have entire conversations in acronyms, and HCBS and LTSS are two of those acronyms that come up really frequently. So LTSS is the broader term, particularly when you're talking about how it pays in with payers. HCBS is the home and community-based services, so things like chores and home care services and meals and those types of things that help people stay independent. Just to add a little bit more lingo into the loop, a lot of times HCBS, or home and community-based services, are called either elderly waiver or waivered services, because if Medicaid is going to pay for them, you have to go through an assessment process. So you have to meet the Medicaid criteria, and then you have to meet kind of a functional assessment. It's oftentimes called an LTSS assessment. So if I meet the income criteria and somebody comes out and does a screening with me to understand whether that I meet this functional assessment, then Medicaid will pay for my home and community-based services to help keep me in my home rather than put me in a nursing home, because certainly it's less expensive for Medicaid for you to be in your home as long as possible as well. So some of the acronyms too, I hope that helps make sense of some of that. The process, the assessments, the different thresholds, those all vary by state. So it's anytime you're starting to talk about Medicaid, it starts to get complex times 50. So LTSS and HCBS are used a lot in these conversations, and I thought it might be helpful just to make sure we're kind of on the same page in terms of what those acronyms mean. Yeah. And thank you, Jill. Jill did mention Medicaid does take assets as payment, so a lot of times there is like a spend down, so you would use against the value of your house as part of your Medicaid payment. So you hear about people spending down to meet the Medicaid criteria. And you don't have to be paid by Medicaid for these services. There is private pay, but Medicaid does end up typically being the primary payer on a lot of these. Some other examples, just to add a little more complexity into the mix. Some states have waivers from CMS where they actually integrate the Medicaid and Medicare funding. What this looks like in rural areas can be pretty mixed. PACE is probably the most common of those programs, so some of your states may have a PACE program of all-inclusive care for the elderly. That may or may not be available in your rural communities, so typically a PACE program has medical and non-medical services kind of all wound together, and Medicare, the dual eligible people are assigned to the provider that then gets paid kind of a bucket to provide all of those services for them. In Georgia, there's something called the Service Options Using Resources in a Community Environment, which they have regional centers that kind of manage that. In Minnesota, it's actually managed through the healthcare, through the managed care organizations. It's called Minnesota Senior Health Options. There's some great acronyms, and so some of this is going to vary by state. Again, PACE is in multiple states, but there are also some state specifics. So that's something to consider as you're thinking about how does this all fit together in your state, particularly for those folks that are on Medicaid and Medicare. A couple of resources if you'd like to dig into these details. There's a Integrated Care for Older Adults in Rural Communities. It's a nice paper by the folks at the Maine Rural Health Research Center, and then the RUPRI panel did a long-term services and support primer that talks a lot about kind of the policy details as well. Shifting gears a little bit so that we kind of talked about big picture, what does long-term care services look like, what is some of the Medicaid lingo. I would say one of the most important service providers or links to services to know about is the Area Agency on Aging. They might be called something different in your community. So they were formally established in 1973 by the Older Americans Act. There was a tribal programs were added to have similar services in 1978. So they do have kind of a small core of federal funding, but there's really wide variation in their structure and services that they provide. So some of them might be called Area Agency on Aging, some of them might be called Senior Resource Centers, some of them might be called County Senior Resources. It is really kind of a mix depending on whether or not they're nonprofit, whether or not they're county-based, whether or not they're state-based. And the types of services that they provide really end up being what I think the easiest way to describe it is kind of a patchwork of federal, state, local, and private dollars that mix together. And so it's, we always kind of like to joke, if you've seen one critical access hospital, you've seen one critical access hospital. You can kind of multiply that here because there's just a lot of complexity and variation, particularly across states, but even within states about the types of services. But there should be coverage in all states for some types of service related to Area Agency on Aging. One of their key roles is to provide local information and referral assistance to help older adults find resources and services. So even if they're not a direct service provider, which many of them are, one of their roles is to help hook people to services. So there's a national elder care locator website and phone line that you can look at to try to identify services. But many states and regions also have their own resource portal. For example, here in Minnesota, we have something called the Minnesota Senior Linkage Line, which is where you would go to access that information. And then just to add another layer, many of the area agencies on aging actually serve as aging and disability resource centers, so they focus on both, but not all. It's kind of a mix. So I'm not trying to confuse you. I'm just trying to share that there's a fair amount of complexity regarding what services are available where. This will help give you some hints if you're not already familiar with these folks. This is a map that lists the state units on aging. So every state does have a state unit on aging. That's kind of, if you have local or regional AAAs, the state unit is more of a coordinating body. In some states, Wyoming or Dakota, for example, some of the lower population states, the state unit is also the kind of primary service provider. And then there's also a lot of tribal organizations. So this link here will take you to kind of the different folks. So I know that was one of the things I encouraged you to think about in your homework is if you don't already have a relationship, particularly with the folks in your state unit, I would encourage you to go there. Maybe not right now. I know a lot of them are really swamped with COVID response, but if that's not somebody you're already talking to, they would be great resources to be talking to and understand how your critical access hospitals might be tapping into their services and resources. So this is a bit of the laundry list of the types of services that Area Agency on Aging provides. There's caregiver support, elder rights. I did really want to call out this evidence-based health and wellness programs because I think that has a really important tie into some of the population health work. To get their funding, if they want to do this type of programming, they actually have to use evidence-based programs. There's a list of the approved programs here that you can take a look at. Matter of Balance, if anybody's heard of that one's around fall prevention. They do some chronic disease self-management programs. So there is actually more and more often the folks that do this local services are working with these evidence-based programs to try to focus on prevention and chronic disease management. So that's a really good tie-in if your critical access hospitals aren't already connected to that. They are oftentimes, in addition to maybe just being a referral source, they do sometimes actually provide the integrated care and transition support. So they might do the home and community services for either the Medicaid managed care or Veterans Choice programs. So they might actually be somebody at the AAA might actually be the care coordinator hooking them together. They might be the ones that have the contracts with the people who do homemaking or other services and chores. So it depends. Nutrition, Meals on Wheels, congregate dining is another common one, legal assistance and financial support programs, and whether or not that's hooking them into heating assistance programs or other services that might be available. Because we love our acronyms and there's not ever too many programs called SHIP. There are a lot of times the area agencies on aging are also the SHIP programs, and this SHIP means State Health Insurance Assistance Program. So those are typically either volunteers or staff that have been trained to help people understand how to sign up for their insurance benefits, help you navigate through your Medicaid choices. A lot of times they support senior center. There's a lot of social activities, volunteer opportunities, transportation services, and more. So there's a list of kind of all the federal types of programs that are funded here. And again, I think a lot of this ends up, because it's such a patchwork in terms of how services are delivered, it's just because some aging services do these programs, all of them don't. It's been a few years ago now, but one of the communities I was working with for palliative care was like, please be talking to the AAA, please be talking to the AAA. They finally had a call with the AAA, and they found out that even though the AAA offered lots of services, they didn't have any service providers in their particular community. So that was great, but not helpful. But from that discussion, they actually started talking about how, well, part of the reason we don't have any service providers in your particular town is because we never get any requests. So how do you kind of link together kind of the needs and the services that are needed in your community? So even if services aren't there, there might be opportunities to try to develop those networks. Okay, I'm going to pause on area agencies and agency, and some of you may know more about them than I do, but is there any questions on that? Because the next kind of little bucket we're going to talk about is really more focused on healthcare delivery.
A reminder, *2 will unmute your line.
Okay, I'm going to keep going because I want to get to the opportunity piece. So the next piece I wanted to talk to, the next piece is a couple pieces are more around what I think I would consider kind of traditional healthcare delivery. I thought it was important to give you some definitions and distinguish between home health and home care. They a lot of times are used interchangeably, but they do actually mean kind of two different things. Home health care is actually skilled nursing and therapy services. A lot of times it's after a hospitalization or an illness. You have to be, if you're going to get paid by Medicare, you have to be a Medicare certified agency, and you have to have medical orders to start that care. So it's a specific medical skilled nursing and therapy service. Home care is sort of this broader definition of non-medical services, covers some of the things we've been talking about already in terms of assistance with activities of daily living, homemaking, maybe respite care for caregivers. So those are all kind of bucketed under home care. Oftentimes, agencies that offer home health care, so that skilled piece, also offer home care services. So there's not a clear distinction a lot of times, but there is in terms of kind of the payment and the certification piece. It's important to kind of divvy those two out in terms of there's actually, if you're a home health care agency, you're certified, you have data reporting requirements, you are providing kind of medical skills, where the home care piece a lot of times offered by the same organization, but is much more broad. In terms of rural access, if you look at the data, most U.S. counties have access to a home health agency, and by that I mean home health care agency. Rural counties are more likely to be served by a single agency, which certainly puts them at higher risk for access to services. And I would guess if any of you are talking to your rural communities about home health services, you know that financial viability is a challenge. And even though on the map or in the data it might say that there are home care services in your county, it doesn't mean that there's necessarily home care services in your community. So I have some personal experience with that. My grandmother needed some home care therapy a few years back, and certainly there's a home care agency in their county, but there wasn't anybody who could do therapy services in her town, which was 30 miles from where the hub and where the agency was located. So it can be a mix in terms of whether or not there's truly access. And yeah, is home care paid by my Medicare or Medicaid? Kathy, that's a good question. It kind of depends. If you've got anything out of this conversation, it depends. So Medicare will pay for home care if people meet the criteria. You have to be considered homebound. It has to be line up with signed medical orders. You have to meet certain criteria. But Medicaid may also pay depending on kind of how that plays together with your benefits and your dual eligible services. Medicare won't pay for the home care activities, some of the activities of daily living, homemaking, where Medicaid might pay for that if you meet the criteria to have those home and community-based services. So it's complicated fast. And so Arizona, Jill says, Arizona does have at least one hospital that doesn't have home health, and that doesn't surprise me. So I said, if you look at the data, a lot of times it shows that there's coverage in every county, but whether or not there's actually services if you refer somebody can be a different question. Nursing homes, I'm using kind of that broader term of nursing homes, but there's a lot of terminology here which can sometimes be confusing and is oftentimes used interchangeably, typically used interchangeably. Nursing homes, skilled nursing facilities, long-term care centers, long-term care facilities, extended care facilities, those oftentimes all get used kind of in the same terminology. The skilled nursing piece is typically focused on when there is, a lot of times when people have a surgery or a hospitalization, they have a specific need for skilled nursing or therapy services, where a lot of times a nursing home is more broadly custodial services or residential services. Most places do both. It's not typically an either or. So the terminology in general kind of gets used the same across the board. Who pays for it, again, varies some. For Medicare, if you've had a 3-day stay, then they will pay for up to 30 days of skilled care afterwards. Medicaid a lot of times does end up being the primary payer here, particularly once folks have gone through their assets. In terms of rural access, I'm going to guess as you drive across your states, you see lots of nursing homes in those little towns, but there have been more than 440 rural nursing homes that have closed over the last decade. This has been starting to get a fair amount of attention, which I think is not a bad thing. Both the New York Times and the Washington Post have had some pretty poignant articles in the last year. Those are the links to those articles there, talking about kind of the back-end issues of those when their nursing homes close in rural communities and what happens to the families and the travel and distance that they have to happen. Also, the Leading Age, which is one of the nursing home trade associations, recently did a really nice summary of what's happening with nursing home closures and trends, and then, of course, RHI Hub. So Stephanie asks the difference between long-term care and nursing homes. There's not really a difference. Nursing homes are a type of long-term care. The only difference I would say is when you're talking about a skilled nursing facility, that very specifically means that you need have a skilled nursing or therapy need. But most of the time in most of your nursing homes or long-term care centers, they provide both kind of just plain old custodial care. So a lot of times I might be in a nursing home, I don't have a skilled therapy need where they anticipate that I'm going to continue to improve, but I also can't be by myself and be at home. So then it's more of a custodial care. So I would say no, SNF and long-term care there can be different, but a lot of times they're used very interchangeably. Okay. I'm looking at the chat while I'm talking to you all. Yeah, lots of terminology and not used consistently. So I'm hoping that I'm not confusing you more and trying to provide some clarity about kind of how it all fits together. Hospice and palliative care, this is the last kind of medical services area that I'm going to talk through. I would gladly talk to you for an hour just about palliative care, but I get like 2 minutes on this topic right now. Hospice is very specific. It's around care for people who are experiencing terminal illness. If you're on hospice and the hospice benefit, you're no longer receiving curative treatment. It's really focused on compassion and caring, quality of life, helping patients and families. The services and the eligibility are really defined by the Medicare hospice benefit, and you have to be eligible for that, you have to be Medicare certified. So certainly there are some private services out there, but when we generally talk about hospice, we're talking about Medicare certified hospices. access to them in rural is a mix. I'll talk about on the next page. Palliative care is much broader than that. So when we talk about the difference between the two, a lot of times we like to say that all hospice is palliative care, but not all palliative care is hospice. So palliative care is broader, where it's a team approach that focuses on quality of life, people with serious illness. It focuses on pain and symptom management. What are the goals of care? How do you reduce the stress of patients and caregivers? So that piece of that, how it's structured and that might look like, is similar to hospice, but it's not only at end of life. So palliative care is really appropriate at any age, at any stage in a serious illness, and can be provided along with curative treatment. So you might still be receiving active treatment for your cancer, but also have a palliative care team that is working with you to talk about what your goals are, what you kind of might want to do for your advanced care planning, how to really provide relief from your symptoms and pain. So those two pieces can come together. Palliative care can be integrated really into any healthcare setting, and it really is intended to provide an extra layer of support around your provider team. It is not defined by a consistent benefit or payment and is not regulated as a separate agency or service. So you see a lot of inpatient palliative care programs, so that's really where it kind of built out of. Most of the expertise at this point in time really sits in larger healthcare facilities in an inpatient setting, but more and more over the last 5 to 8 years has been a push to get those services out available much more broadly in the community. So you might have palliative care teams working in your nursing home, working in your with your home care agency, having clinics, doing home visits. So kind of broad in terms of what that looks like. Access to these things, access to hospice and palliative care services in rural communities varies pretty widely. When you look at hospice utilization as a nation at large, hospice utilization has been increasing, but your utilization decreases with rurality. So if you're in an urban area, you're much more likely to be accessing hospice services than you are if you're in a frontier. So a lot of that is just availability. I know there's been a lot of communities we've worked with around palliative care that just simply don't have access to hospice services in their community. So there's some variability there, but it is kind of a mix. In terms of palliative care, most of the data that's available is around inpatient palliative care services. 94% of the hospitals that have more than 300 beds have a palliative care program, but 36% of hospitals with less than 50 beds do. So when we've worked with rural communities to set up palliative care programs, it's typically been kind of, you have a palliative care team and then serves, if they have people inpatient that need it, they do there. They might do home visits, they might do clinic visits. It's really kind of much more broad, whereas if you're in a larger urban area, typically your teams are more setting specific.
Hey,
always
Carla?
happy to talk about palliative care. Yep. Go ahead.
If I can remember correctly, does Medicare does not pay for palliative care, or has that changed?
Not as a specific benefit, no. So that is one of the biggest challenges. So if I'm in a hospital, particularly a larger tertiary hospital, a lot of times how I end up paying for my palliative care program is that I help people sort through goals of care, and I get people out of ICU or out of the hospital sooner, those types of things. Some folks do, there is some reimbursement for advanced care planning and for chronic care management that can be utilized. I actually have, I don't think it's linked in here, we've actually done a whole guide about how rural programs are paying for palliative care, and it's kind of a patchwork. Some places are just doing it because they think it's the right thing, which isn't super sustainable or expandable. Some are doing some reimbursement. It really ties in well to value-based care if you're under those contracts, because if you are focused on kind of like the whole aging service piece in general, tends to focus on keeping people healthy and in their homes. So if you can do that, then a lot of times you might have less visits to the ED, less inpatient hospital stays, those types of things. But payment is a really significant issue. Yeah. And I can spend an hour talking about that too, and I have, but I won't today. So if you want to talk about palliative care, always happy to talk with you guys about that offline. It is an area that I think my colleague Janelle and I that do this work, we kind of joke that we know it's not okay to have favorite children, but we do have favorite projects, and it's definitely one of our favorite projects to work on the palliative care access issue. Okay, I'm going to take a breath, and then we're going to start to talk about opportunities. So I pulled out what I think about population health, in particular critical access hospitals, and what are opportunities related to population health that might make sense aligned with aging. One of the top ones I think is important is to think about advanced care planning. So I had to start with a couple definitions here. Advanced care planning is really the process of making decisions about what type of health care you want if you're facing a medical crisis. And an advanced care directive is actually the documentation. So those two words those two terminologies get intermixed quite a bit. So there's kind of a planning process, and then there's actually like a paperwork process for legal documentation. And it is actually strongly encouraged that all adults should have an advanced directive. So if you don't have one, I would encourage you to be thinking about that. The next layer of the puzzle that oftentimes gets raised is what's oftentimes known as POLST or MOLST. There might be a different acronym in your state because that's the way we like to do things. Generally, it means provider or medical orders for life-sustaining treatment. This is really focused on inappropriate for individuals with serious illness or frailty near the end of life. So this might be where you consider a do not resuscitate order, whether or not you would want to have tube feeding, those sorts of things, of those really kind of specific closer to end of life or frailty decisions. A lot of times now, if you're going into a nursing home or a long-term care center, they are kind of heightening the awareness and doing more work with POLST. This has been, in our current COVID world, a really significant piece of the puzzle and the pie when people are thinking about what happens if this comes to a nursing home, what are the plans that have been in place. So I actually think that our current environment, if nothing else, is really going to heighten the need for advanced care planning and considerations around this, which is why that was part of your homework assignment, is to look at that. I think the Conversation Project has a really nice resource there. So a couple of resources to think about. Most states have something called either Honoring Choices or Respecting Choices, which are organizations and resources that focus on advanced care planning. The National POLST paradigm has kind of pulled together and coordinated kind of the POLST or MOLST data and information for across the country. The Conversation Project is really focused on encouraging individuals to have that conversation with their loved ones, because when it comes right down to it, particularly if there is no advance directive and is no legal documentation, it all comes down to what your family says they think you want. So having those conversations is really important. And then there's just a really nice article on advanced care planning and population health. ACP Decision is got some electronic products. I'm not endorsing, and I'm not saying, I don't know much about their products. I just really like the article. So I wanted to share the article, but not say, hey, you should be using their products. I don't know that much about their actual products. I just like the way that they talked about it in the article. So that's a nice link there for you as well. One of the next opportunities I think is important to think about is something called age-friendly health systems. I'm hoping most of you have heard about this. The Institute for Healthcare Improvement, or IHI, has been spearheading this work and has been making the rounds at both rural and non-rural conferences of late. It really focuses on a 4M framework where they're encouraging health systems to consider that every time they have an older adult, which I think they define as 65 and older, that they are assessing 4 things. So what matters to that person, either in their life or at the visit, that kind of gets to the advanced care planning piece. What are their medications, and are they kind of making sure they're paying close attention to that? Mentation is really kind of looking at mental status. Are you kind of looking for early detection of Alzheimer's or dementia? And the mobility is around kind of fall prevention and what's happening in terms of whether or not they can move safely in their day-to-day life. So I've got a link there for you to the Age-Friendly Health System page on the IHI website. And then if any of you have geriatric workforce enhancement programs or GWEP programs in your state, which many of you do, the GWEPs are currently doing a focus on age-friendly health systems. So the link there will take you to their coordinating center, which would help you find your local GWEP program in your state. So they're a nice resource that I was in most states and are working on age-friendly health systems right now. A third opportunity, which I'm not going to spend a lot of time on because I know you talk about it in lots of other aspects of Flex, but is just right around the whole aspect of care coordination, whether or not it's just straight up care coordination in the clinic, whether or not it's a broader look at palliative care and how that all fits together, but certainly opportunities to help supplement and connect both medical treatment and non-medical services. I didn't talk about behavioral health. I know that you guys talked about it not last week or at your last session, but that certainly plays into all of this. So a handful of resources there for you around care coordination. You can see lots of importance on it, lots of resources on it, so lots to talk about there. And then the last opportunity that I wanted to highlight is just to encourage, if you're thinking about population health, what ways can critical access hospitals kind of bolster community services? That might mean actually developing and offering some of those services, but it might mean just working with partners locally to offer those services. So I always would encourage folks to first partner, understand what else is happening in your community before you start to roll out a service, because certainly you're much more well received if you're kind of working with others instead of going it on your own. But there could be everything from caregiver support, some of the chronic disease or healthy living classes. Lots of communities have started focusing on the healthy food access. For example, we have a critical access hospital here in Minnesota that hosts a farmer's market in their parking lot and has CSA shares that they use as prescriptions so people can get access to the community-supported agriculture shares, has done a lot around that. Housing options, one of these profiles I have linked here out of Chadron, Nebraska, actually their hospital board recognized that they were having folks leave their community because there wasn't housing options and decided that they needed to build an assisted living. The other profile I've linked for you here focuses on the First Health of the Carolinas, did some integration of medical legal partnerships, so trying to address both those social and legal issues. So bolstering community services is always an opportunity, I think, for critical access hospitals to understand what the gaps are and how they can connect with partners in their community. Just briefly, how this fits with value-based care. So certainly most of the strategies that kind of help support aging services and kind of long-term care can help reduce potentially avoidable utilization, which help reduce cost of care, can also increase patient experience, and depending on what you're doing, it might align with the quality metrics if you think about those kind of three key tenets of value-based care. There are some reimbursement opportunities. Talked about these briefly with the palliative care. If your critical access hospitals have a hospice and or a home care, if you're doing a good job with care coordination and referrals, that can also help. That's one opportunity to kind of capture reimbursement if you're increasing utilization or length of service for those. The other one feels a little bit blunt, but honestly, if you're doing a good job of this as a hospital, it's pretty good marketing in your community. It can help increase perception and goodwill and quality of life and all sorts of things. I know one of the rural communities we worked with decided that they're getting the palliative care program off the ground was important enough that they actually pulled some budget out of their marketing to help support time for the coordinator to get that up and running, because word of mouth and having satisfied people in their community was so important. And then finally, grants or philanthropic funding they're a really good option, particularly for supporting development, for long-term service delivery support. That can be a little bit dicier, but especially supporting development. And I would be remiss not to mention the multitude of community-based division programs that are available through FRHP that might be good opportunities to kind of develop this type of support. There's your health value. There's me. This is my parents more recently. My mom was really proud of the masks that she made, so I had to share this with you as well. I'm going to stop talking. I didn't quite make 40 minutes. I made 50 minutes. Questions, observations, thoughts? What are you guys thinking about? I hope some of you did the homework. I hope that you found some interesting things.
Yeah.
Carla, I've got a comment. Yeah. Let me jump in, Caleb. Yeah, on a number of things here. I could probably talk for an hour here too on these, because there's so many issues here wrapped into. But since we're talking about families and mothers in that regard, one of the issues that I think is really, really important really has to do with medication reconciliation. And I'll give you an example of my mother, who was in an assisted living facility for memory loss. And she very fortunately was able to have access to hospice. And when the hospice nurse came in, the hospice nurse was empowered to take her off the medications that she had been on. And once they took her off the medications, her memory came back. And this is not a unique situation. I remember at a reverse site visit last year, we had an EMS workshop and associate with that, and we had a paramedic come in and talk about a program coming out of Allegheny Health System where they'd use care coordination and use a community paramedic to go in to basically visit people, mostly older people in their home. And included in the team that person had was a pharmacist who was able to reconcile the medications of those people. And when I asked them what percentage of the people in the home setting had inappropriate or had some need for drug reconciliation, he said 100%. So, I mean, this is confirmed talking to pharmacists, et cetera. This is just, this nasty little situation where we're not reconciling people's drugs. And, the use of hospice, palliative care, et cetera, is becoming a very important tool in accountable care organizations, global budgets, et cetera. So I think we're moving in the right direction here, but the disconnect between our long-term care system and our acute care system is one that, TASC has taken on, and, last week we conducted a summit meeting on this, and we should be publishing here a white paper on the results within a few months. So, and I also want to thank you, Carla, because you have been a champion for this for as long as I've known you.
Thanks, Terry. Other
Thanks, Terry.
trigger thoughts or ideas for anyone else?
Yeah, how did you guys, do you have, so we have just a few minutes left. I want to make sure we make the best use of Carla's time that we can, and most of the time for me that's asking questions. So do we have any questions for Carla about the presentation and aging services or the homework that was provided, or just in general? I thought there were some great suggestions there on what can be done, both from the flex programs as well as the hospital. Star 2 will unmute your line.
Well, this is Stephanie from Idaho. I just wanted to say that the homework was really well lined out. It really helped to have it sort of mapped out, your suggestions for where to look. Most of those resources I didn't know about. I am just recently, actually within the last couple of months, well, pre-COVID, right before COVID, got in with the Area Health on Aging here in Idaho. And we had conversations before, but never, like to support different efforts when applying for grants and looking at ways we could collaborate if they got funded, but then they wouldn't get funded, and so then it kind of dialed back a little bit. But they let us know about their strategic plan, and just kind of being at the table for that and realizing that's a whole other resource that I hadn't really tapped into. And I thought that this was really great for sort of peeling away the layers of the onion, because this is really complicated for me, because I use some of these words interchangeably, and then when I hear you talk through them, and like we're just now starting to tap into ideas for palliative care. Washington is a great resource for palliative care, and so just having some of those one-off conversations, but being able to package it like this, and it was amazing you did it in 50 minutes, but I tracked everything you were talking about, and it's a really great, I wish this would be available to all flex coordinators, maybe it's one of those things that comes about and you pick it up when you're ready kind of thing, but it was incredibly helpful to hear. And then just on a personal level, like my grandma is literally in this process right now, but like during COVID, right? So not being able to be there while they're in the hospital and trying to figure out what's the next step. You know, is it long-term care? Is it nursing home? Is it trying to see if there are services that could still help her in her home, and who pays for that and how does that go? That is really hard and complicated from a family member's perspective, let alone from like a flex coordinator's view of how do I support maybe a flex initiative to transport hospitals who may be coordinating with long-term care or something like that. So anyway, thank you very much. It was very timely and very much appreciated.
Thanks, Stephanie. Yeah, and it's a challenging time, so I wish you and your family well with your grandma.
Yeah, absolutely. Yeah, thank you, Stephanie. And so somehow, some way, this will be available to all flex coordinators. So if it's the recording of this presentation or the resources, the packaging of it, so it will all be available, Stephanie. But it's good to know that it's as beneficial and helpful as it is. I will have Andy put up the polling questions, the exit polling questions, just in understanding of your guys' time. I know Jill had to jump to another call. Any other comments, questions, thoughts for Carla?
And I think most of you either I know you personally already, or I would be happy to get to know you. So happy to take questions offline or talk to folks. Oh, I do see one in the chat. Kathy, oh, good question. Where does assisted care fall in this? In most states, assisted living is a non-regulated service. That's starting to change in some places. For example, Minnesota just put some laws in place that's going to put some more framing around what it means to call yourself an assisted living. But it would be kind of one of those generally long-term care services would be kind of on the residential end. But what you mean by assisted living is one of those really messy thickets around what that definition is. So happy to have further conversations offline. Thanks for the opportunity. There's a lot of information. I'm glad to hear Stephanie found it was helpful. Hope others did as well. It was kind of fun to put it together. It's kind of all in my head, and it was like made me really think about it.
Yeah, we had a CEO ask if his hospital living facility had a test for COVID-19.
So that's a really good question. I would kick that to your Department of Health, but I would certainly think it would be a good idea, but then I also know that resources and access are also an issue. So, Kathy, I would definitely bring that to the folks at your Department of Health or whoever's leading the COVID response in Texas.
Yeah, so to Carla's point, any questions, I remember seeing Carla's contact information in the slides, which are available in the file share button down below. Email Carla or myself or Andy, and we'll get you connected to Carla or the appropriate party. Thank you, Carla. We really do appreciate having you participate in the learning